Ah, Estamos com 5 minutos depois da hora prevista. Vamos então dar início. Good afternoon, everyone. Dr. Francesco Manelli, Dr. Patricia Silva, thank you very much for your availability and collaboration. I will start with a brief introduction in Portuguese before passing the word to you. É com grande satisfação que a APORMast, a Associação Portuguesa de Doentes com Mastocitose e Doenças Mastocitárias, realiza hoje o seu primeiro webinar subordinado ao tema Fisiopatologia e Tratamento das Doenças Mastocitárias, com o objetivo de contribuir para a consciencialização, divulgação e partilha de informação sobre as doenças mastocitárias. Queremos desde já agradecer a todos os participantes pelo interesse demonstrado e agradecer ainda de forma especial ao nosso orador convidado, o Dr. Francesco Manelli, e à moderadora da sessão, a Dra. Patrícia Silva. O Dr. Francesco Manelli é médico hematologista e investigador da Universidade de Florença, em Itália. Licenciou-se em Medicina pela Universidade de Florença em 2002 e concluiu a especialização em hematologia na mesma instituição em 2006. O seu principal foco clínico e científico reside na gestão de doentes com patologias oncohematológicas, com especial ênfase na leucemia aguda e mastocitose sistémica. Está profundamente envolvido em investigação translacional nas áreas de correlação fenótipo, indicadores prognósticos, diagnóstico e monitorização da doença residual mínima. Destaca-se a sua colaboração com o reconhecido professor Alberto Orfo, no Laboratório de Citometria de Fluxo da Universidade de Salamanca, onde aprofundou técnicas avançadas de análise celular com aplicação no diagnóstico e monitorização de doenças hematológicas. Atualmente, o Dr. Manelli integra a equipa de investigação da Universidade de Florença, no grupo Minerva, no âmbito do programa de investigação financiado pela Associação Italiana de Investigação em Cancro, focado em alvos terapêuticos na progressão clonal e disseminação sistémica de neoplasias mieloides. Destacam-se ainda os seus papéis como co-investigador principal de ensaios clínicos multicêntricos no âmbito da leucemia mieloide aguda, contribuindo para o avanço do conhecimento e terapias nesta área. A doutora Patrícia Silva, nossa moderadora, é também médica hematologista, concluiu o mestrado integrado em Medicina pela Faculdade de Medicina da Universidade de Coimbra em 2009, realizou formação específica em hematologia clínica no Instituto Português de Oncologia do Porto, onde obteve o grau de especialista em 2017. Exerceu funções como assistente hospitalar em hematologia clínica na ULS São João, no Porto, e atualmente integra a equipa da ULS de Matosinhos. Antes de iniciarmos, e para permitir uma melhor qualidade da ligação e estabilidade da reunião, gostaria de pedir a todos os participantes para manterem os seus microfones desligados e evitarem utilizar as câmaras e colocarem as suas questões por escrito através do chat. As questões colocadas serão analisadas e apresentadas pela doutora Francisca em inglês ao doutor Francesco, no final da intervenção. E desde já agradeço a vossa colaboração e desejo a todos uma sessão profícua. Passo agora a palavra à doutora Patrícia Silva.
Muito boa tarde a todos. Espero que me estejam a ouvir. Agradeço a vossa presença neste webinar. Faço primeiro uma pequena, outra vez um realce àquilo que já foi dito, portanto, durante a sessão, por favor, manter os microfones desligados, as câmaras, e as perguntas serão feitas no chat e mais tarde eu traduzirei ao Dr. Francesco. Agora vou falar um bocadinho. Welcome, Dr. Francesco. Thank you for your collaboration. Dr. Francesco Manel will present us a current review of the pathophysiology of mast cell disease and the therapeutic options that are available today. Please.
Okay. So good evening, everybody. And it's a pleasure for me to speak today. So thank you very much for inviting me. I hope you can see the presentation. So it's fine for you? Can you see it?
Yes, we can see it.
Just a confirmation. Thank you very much. So in my presentation, we will touch these topics. So I've identified the main topics here, the diagnostic criteria, and we will review the recent updates by the current classification. Then we will talk about clinical scenarios and which are the diagnostic procedures that allow us to get the diagnosis, the classification in clinical variants that, as we will see, is the main basis for treatment. And then we will talk about treatment, focusing on the multidisciplinary management and supportive therapy, and then on cytoreductive treatment. As a further request, we will have a specific focus on eosinophilia within systemic mastocytosis, and we will start from a clinical case, and then we will address this topic also. So the first issue, we know that systemic mastocytosis is not a disease. Rather, we can say that there are many diseases. It's an heterogeneous group of diseases that share the proliferation, accumulation, and activation and abnormal behavior by pathological mast cells. And this leads to several and very diverse clinical manifestation that can involve so many organs. And well, up to 2008, the WHO classification included systemic mastocytosis within myeloproliferative neoplasms. The change from we would say, conceptual view came in 2016. From 2016 on, mast cell diseases are considered separate categories, basically in view of their unique clinical and pathological features. So no more myeloproliferative neoplasm, but just systemic mastocytosis. And what we've seen from 2008 up to 2022 were some refinements of the diagnostic criteria, but without big changes. So the common issues when we talk about diagnosis is the fact that it's an integrated diagnostic. So there is not just one technique that we can use to get diagnosis, but rather we have some core laboratory data that actually need to be integrated to get the diagnosis. And there are, as we will see, some different criteria, the major one and the minor ones that are several, aiming to identify abnormal mast cells. That is the specific purpose of diagnostic methods. And the combination with which the criteria are integrated to get the diagnosis has basically remained the same. So we need one major criterion together with one minor, or the presence contemporarily of three minor. And these are the criteria. We will see them in details, but the first one concerns histopathology. So the capability of a biopsy, mainly bone marrow biopsy, to highlight the presence of infiltrate.
Sorry, Dr. Francesco, I'm sorry, but your slides are not passing, are not showing the presentation. Excuse me.
Okay, so maybe I need to share. because it's like it has blocked my. It doesn't allow it doesn't allow me to share it anymore. It's like blocked the condivision. I mean the possibility to share. Well, perhaps, yeah. Can you see it now?
Yes.
So sorry for that. So this is the list of the. Do you want me to go also before? It's fine from here for you.
Now we can see.
Okay, so it's fine from here on.
Yes.
Okay. So the major criterion regards histopathology. So deals with the capability to highlight the presence of multifocal dense infiltrates of mast cells. But well, generally we say in a biopsy that in the large majority of cases it is a bone marrow biopsy, but it can be also extracutaneous organ. The minor criteria regards specific techniques. Each of them highlights an abnormality. So the first one is a morphological abnormality of mast cells, and we need to have more than 25% of mast cells that we see in the smear to be atypical, to have the criterion met. The phenotype, so the abnormal expression of proteins, specifically CD25 and CD2, at least in these, there were the criteria of 2016. Molecular genetics, so the presence of an abnormality, a genetic abnormality that is, in the large majority of cases, a mutation in KIT gene, specifically involving codon 8016. Then we have another criterion that doesn't deal with bone marrow or other organs, but deals with tryptase level, and we will see that. So what is important to say here is that there are several cases in which we are not able to meet all the criteria, but we have, for example, the positivity for one between immunophenotype or molecular genetics. That means that there are clonal mast cells in our patient, but we are not able to meet all the criteria. So in this case, normally we use this term, monoclonal mast cell activation syndrome. That means that is a clonal mast cell disorder that probably doesn't reach the full presence of the disease to get all the criteria. Just to see some updates coming from the 2022 updates of WHO and ICC classification for specific criteria. So the major criteria, you can see from the image here, the presence of the dense infiltrates. What has been highlighted and specifically stressed by the classification is the need to highlight mast cells by using immunoreactivity for tryptase and CD117 specifically. So just not to miss the presence of mast cells in some cases. The morphological criteria has remained the same. So we have this percentage of 25% that is considered a threshold to consider mast cells abnormal. Actually, we have to say that it's quite challenging, especially in cases of patients with indolent disease, to highlight sufficient number of mast cells to evaluate accurately the abnormal morphology. What we see in the images are the typical abnormality, we could say. So the presence of spindle-shaped mast cells. Then we can have some other abnormalities, the immature appearance or other atypical appearances. Well, molecular genetics is probably the field in which in the last years we've seen many advances. So it was an issue to have more than half of cases that were negative for KIT mutation. But that was due to the molecular techniques that were used up until just some years ago. Then, by the application of some quite simple recommendations, so the use of unfractionated bone marrow cells, because the processing of bone marrow led to the loss of mast cells, and so increased the probability of a negative result. And the other thing was the use of PCR assays, so with higher sensitivity as compared to the Sanger sequences that was considered the conventional technique up to some years ago. So by applying these two recommendations, now we know that up to 95% of cases of mast cell disorders have harbored this specific mutation. And from this point of view, the 2022 classification have also added the fact that other rare non-D816V mutations, so non-canonical mutation, can activate KIT and can be used as a marker of clonality. What the classification state is that we would need at least some published evidence available. That is not easy, but we know now that many non-canonical mutations have been described involving all the domains of the KIT protein. Coming to phenotype, we know that historically the two antigens that need to be evaluated and expressed and considered to be aberrant were CD2 and CD25. What is difficult for the flow cytometry lab, that is normally the lab that is involved in this part of diagnostics, is the fact that mast cells, even in pathological bone marrows, are very few. As you can see here from these numbers, there's a large overlap between the amount of mast cells in healthy subjects and in bone marrow of patients with indolent systemic mastocytosis. So the fact is that the amount very often is not increased, but what you need to do is to highlight the presence of aberrancies. And that's not easy when we are talking about so low percentages of cells in the bone marrow. So the flow cytometry lab needs to be skilled, need to have competencies specifically in this kind of diagnostics. The 2022 classification has modified this specific criterion, basically adding CD30 as a potential aberrancy. The reason for that was that, there's a quite rare subset of systemic mastocytosis that has been described by the Spanish group and is called well-differentiated systemic mastocytosis. And in this subset, quite frequently there's negativity for the conventional KIT mutation, and so it's not easy to get the full diagnosis by applying the conventional criteria. But these cases very often express CD30. So by adding CD30 to the immunophenotype, the majority of these cases can get the full diagnosis and be considered systemic mastocytosis as well. That was the reason for this modification. The last criterion is tryptase. As we know, the threshold that has been identified by WHO and ICC has remained the same, is 20. But we have to know that is considered to be abnormal when it's higher than 11, more or less, depending on labs, of course, on laboratories. But the other thing that we need to take into account is the fact that the fraction that is not so low, up to 30%, can be diagnosed in spite of a normal or less than 20 tryptase level. So it doesn't exclude a low level diagnosis of systemic mastocytosis. And the other thing is that, of course, not all patients with an increased level of serum tryptase have mastocytosis, as there are so many disorders, hematological and non-hematological, that can cause an increase in tryptase level. well, the tryptase level has further complicated in the last years, because now we know that there is this quite frequent genetic condition that is called hereditary alpha-tryptasemia. There is a genetic trait characterized by an increased copy number of alpha-tryptase. So basically, a higher number of copies determines a mild elevation in serum tryptase level. And in the literature, there are some reports that describe an increased risk for anaphylaxis for these individuals. Of course, these are not patients, these are normal individuals. So the problem has been raised because, the level of tryptase is an important criterion. And the European group in the last update has proposed an adjustment of tryptase level based on the number of extra copies of alpha tryptase gene. Basically, by applying this formula, that of course has not been formally validated, it's just a proposal and empirically defined. But of course, this is an issue. This is an issue also because in this very important study by the Austrian group, it was seen that in the control cohort, so in the general population, the presence of this genetic trait can reach 5%. So it's a lot. And this study also highlighted another interesting thing, that the mastocytosis, differently from all other myeloid neoplasms that were studied in parallel, the prevalence of tryptase level of hereditary tryptasemia was up to 20%. So higher than in the rest of population and the rest of patients with myeloid neoplasm. And so the authors hypothesized that tryptasemia could be a causative event, a sort of germline predisposition to the development of mastocytosis. But it's just an hypothesis, of course. But we could conduct a study quite recently in a large cohort of patients from all the Italian network, more than 400 patients. And we studied the prevalence of HAT, basically confirming the result from this point of view of the other study by Greiner et al. But what we saw was quite interesting. So was the fact that there was a quite high percentage of cases that were diagnosed with monoclonal monoclonal mast cell activation syndrome. So patients that could not get the full diagnosis due to a very low burden of disease. And clinically, we observed that in spite of being associated with a lower disease burden, also within patients diagnosed with mastocytosis, there were higher risk of cardiovascular complication and especially anaphylaxis. So we could translate it as the presence of tryptasemia could be a further trigger for mediator release and for the risk of mediator-related symptoms in patients with systemic mastocytosis. So, coming to the clinical scenarios and diagnostic procedure, well, we have already anticipated that the clinical manifestation can be actually very diverse and different. And they go from a specific, we would say, systemic symptom like fatigue, constitutional symptom, to symptoms that involve some specific spheres of the organism, from skin to bone disease, of course, to allergological manifestation that are or can be life-threatening as anaphylactic shock, of course, to hematological manifestation, especially bone marrow failure and other, and to gastrointestinal symptoms. So if we, revert the sequence, so how we can suspect the presence of systemic mastocytosis and then evaluate the opportunity to carry out the diagnostics, because we know that, as we have said so far, to get a diagnosis of mastocytosis, we need a bone marrow biopsy. So it's an invasive diagnostics, and we have to evaluate, we have to appraise the fact that carrying out a biopsy is the best thing to do, or probably in other cases is not appropriate. And the main clinical scenarios that we can face at presentation, and that I have divided here, are these two. On one side, the skin involvement, and the other side, without skin involvement. So we know that with skin involvement, the context can be very different between adults and children. So if the patient that we have in front of us is an adult, the clinical onset of the skin manifestation has been in the adult age, it's much more probable that we have to deal with a systemic mastocytosis with skin involvement than with a pure cutaneous mastocytosis. That is completely the opposite if we are talking about children. So in these cases, the probability to have pure skin, pure cutaneous mastocytosis is quite high. And it's a indolent disorder, purely cutaneous, that tend to ameliorate and resolve with years without doing basically anything, apart very, very rare cases. But the fact is that if our patient is an adult, the diagnostics is recommended, because to diagnose and to exclude the very rare situation of pure cutaneous mastocytosis in adults is quite important from a prognostic point of view, and from the point of view of clinical management of this patient. Well, it can be also different in different countries, but in Italy, to get an exemption code, what we call a code that covers the costs for diagnostics, treatment, and so on. Actually, we need to get the diagnosis. Otherwise, we can't give the patient this administrative code. And we have some tools that can aid us to understand if the bone marrow biopsy is we have to perform bone marrow biopsy or not. And in these cases, when we have this situation that is called mastocytosis in the skin, that means that we have mast cells highlighted in the skin, but we haven't performed yet a bone marrow biopsy. We have some variables that can help us to understand if we have to go further with diagnostics. The first is tryptase level. As you can see from the table, there are several tiers here. The presence of bone symptoms, or the presence of other constitutional cardiovascular symptoms. Of course, the presence of one of these gives us a higher score. So an higher probability that performing a bone marrow biopsy, we get a diagnosis of SM. Sometimes the patient are not happy to do a biopsy, especially if they feel good, they have no major symptoms, and so on. So in selected cases, it's possible to be conservative, not to perform the biopsy immediately, and to talk with the patient and to monitor clinically the situation. But we have to know that the biopsy is a necessity to get the diagnosis. And we will see also in the other situation that is the case without skin involvement. Generally, in this case, the patient is referred by an allergologist, or more rarely by a gastroenterologist, in view of anaphylaxis of other mediator-related symptoms. So also here we have a tool that is very useful, that is called the REMA score, because it's been developed by the Spanish network. And it included some variables, that are related to the gender of the patient, and of course for the clinical symptoms that the patient experienced during the crisis. So in the cases of anaphylaxis, and the level of tryptase as well. And it's quite useful. It's the threshold that is considered to be positive is a score of at least 2 points. And in this case, the biopsy is of course recommended. But the other thing that we have to know is that in cases where the anaphylactic shock was due to Hymenoptera, generally the biopsy is recommended regardless of the REMA score, because as we will see, that could be a systemic mastocytosis underneath, causing the very severe clinical manifestation. What is important to know here in this specific context where skin involvement is not present is that the search of the KIT mutation in peripheral blood is featured by a very high false negativity rate that can reach 20-30%. So it can be considered a reliable substitute for bone marrow biopsy. And the other thing is that you decide to carry out a biopsy, you have to be very aware of the skills and competencies of specific laboratories, because each of these laboratories have to be specific competencies in SM diagnostic. If you are not convinced of that, rather refer the patient to a bigger center where a good diagnosis can be performed. Well, classification in clinical variants is the basis for clinical management and treatment, and we will also see the, conventional historical classification of clinical variants, and then we will see some refinement that came from 2022 classification. How we can subclassify the clinical variants? Well, the majority of data come from bone marrow assessment. So when we get a diagnosis, we get also many information that are important for the definition of clinical variants. That is a very important point. Then we need to investigate some clinical and laboratory findings to specifically define some clinical variants. And there are these two categories of findings, as the classification states, that are called B findings and C findings. Well, I've depicted here the significance that you can find in the literature for B and for C, but there are so many that are useful to remember these. But the very important thing is that when we call about B findings, we're talking about burden of disease. When we're talking about C findings, we're talking about organ damage. So something more severe, a further step. And we will see that in detail then. So the classification in clinical variants basically follows an algorithm. The first thing is to the detection of more than 20% of mast cells in bone marrow aspirate smear. That is important to stress. It's not biopsy in this case. It's not histopathology. It's the bone marrow aspirate, the smear. If you have more than 20%, and the more recent classifications stress a lot the fact that it's not just an issue of quantity, but also of other quality of abnormalities, but you have already diagnosis of mast cell leukemia. Then we have another quite important group of cases where you are able to get the diagnosis of systemic mastocytosis, and at the same time, you have the criteria for another hematological neoplasm. And this is a specific disease, a specific variant, because it's a quite frequent occurrence, that you have a systemic mastocytosis together with another hematological neoplasm. In the other cases, you have to search for C findings. If C findings are present, if there's a damage of an organ, and some specific organs are more involved than others, you have an aggressive systemic mastocytosis. In the absence of that, we can search for B findings. So disease burden. If we have disease burden, you have a smoldering systemic mastocytosis. That means it's something that you have to be careful about, because there is no organ damage, but there's a lot of mast cells, a high burden, so you have to carefully monitor the patient. In the absence of B and C findings, you have the indolent form. So which are the main changes coming from the 2022 classification? The first one is that is the definition of another variant. Actually, there's a difference here between ICC and WHO, because ICC consider this subset, I would say, there is bone marrow mastocytosis, called bone marrow mastocytosis, as a sub-variant within the indolent systemic mastocytosis. Alternatively, the WHO separates this bone marrow mastocytosis as a separate variant, a different variant from indolent. What is bone marrow mastocytosis? Actually, it's a subset where you have just the involvement of the bone marrow. So no skin involvement, no B or C findings, very low or quite low tryptase level. So it's a very indolent disease, but we have to know that it's strictly closely associated with severe anaphylactic reactions. So on the basis of these features, it is like separated by WHO and considered as a subvariant by ICC. The other difference in this setting concerns the definition of SM with another hematological neoplasm, as we've said. So the ICC has introduced the concept that to be considered this kind of variant, you have to diagnose a myeloid neoplasm and not, for example, a lymphoid neoplasm. That, of course, was a much more rare occurrence, but it could happen. And in these cases, the ICC wants to underline the relationship clonally between systemic mastocytosis and the other myeloid neoplasm. That is, of course, quite different in the case that you have a lymphoma or another lymphoproliferative disorder. On the other side, WHO still consider AHN the presence of another hematological neoplasm, regardless of if it's lymphoid or myeloid. Within B findings, the WHO has added another quite important criterion, that is the allele burden of KIT. You know, until now, the modality to evaluate the disease burden, as we said, came from the bone marrow biopsy, the level of tryptase that has to be higher than 200 nanogram per milliliter, or the presence of a hypercellular bone marrow, or this myelopoiesis. So there was a degree of dependence on operator, of course, especially for histopathology. So it was not easy. And the inclusion in these B findings of a quite objective assessment, that is the KIT allele burden, was quite important. And the threshold that has been set here is 10%, either in bone marrow or peripheral blood. If we have a look at the frequency with which we encounter the variants in clinical practice, this table is quite interesting from my point of view, because on your left, you have some clinical reports that were published by hematologists, so just hematological groups. On the other side, on the right part of the table, you have multidisciplinary reports. So this on your right is now the best photography, the most appropriate photography of the disease. So before, we actually thought that the more aggressive and I would say advanced variants in general were up to 50% of cases with systemic mastocytosis. That is not the case. We know that luckily, the majority of patients are diagnosed with indolent forms, up to 90%. And that the remainder, so the 10% that remains, is advanced variants. So we can depict our cases just like a reverse pyramid where the basis is indolent systemic mastocytosis. And what we have to care about is the risk of progression from indolent to an advanced form. With a balance, of course, between overtreating and overlooking, that is quite important. But the introduction in this disease of a multidisciplinary approach has radically changed our perception also of the disease. So the classification in clinical variants is so important because we have to choose an approach. I would say a clinical management approach and a treatment approach if that is the case. And we normally divide these between these two paths. On one side, a conservative approach that is reserved to indolent or smoldering cases. And on the other side, in advanced cases, a disease-targeted approach. So a more an approach that is directed to tackle the disease more specifically, to kill mast cells, actually, and not to control the symptoms. Even if this paradigm is challenging in clinical practice and probably is changing due to the progressive inclusion of some treatment options that we will see now. So prognostically, we know that, of course, clinical variance is the best way to evaluate prognosis and to estimate the survival of this patient. This Kaplan-Meier curve is extracted from an historical and very important paper by Mayo Clinic, and then shows you actually that the life expectancy of patients with indolent systemic mastocytosis is more or less superimposable to the general population. That is very important to know. On the other side, all the other advanced diseases significantly impair life expectancy in these patients. So more modern integrated prognostic models to define prognosis have tried at least to overcome the fact that the clinical variant is based on clinical assessment. So it can have some flaws that depends on the clinician, on his experience, on the fact that some exams are done and some others are not. So, it has some defects. So the try was to integrate to the clinical assessment, or to overcome completely the clinical assessment by embedding in the prognostic model some more objective variables, some coming from simple parameters from hemochrome or clinical chemistry, some others, probably the most important ones, coming from molecular genetics, so NGS, especially some mutation as especially those identified by the acronym SAR, that means SRSF2, ASXL1, and RANKS1 are the most unfavorable mutations that you can search for, and that have a very adverse effect on prognosis. And you can see here in the lower part of the slide the three main prognostic models from Mayo, from ECNM, and the global score that have been proposed by REMAScore. So the fact is that all are quite effective. What is not easy is to try to implement these models in clinical practice in individual patients. But we have to know that we have some tools that progressively can aid us to understand the variant in the specific patients. So just some concluding remarks so far. So the fact that the bone marrow biopsy analyzed by different techniques, but is a requirement to get to the diagnosis of systemic mastocytosis. The fact that the study of the KIT mutation in peripheral blood is an important tool, but can't be used as a reliable screening and can't substitute the bone marrow biopsy. Well, that the labs has to demonstrate specific skills and competencies to be applied to have a reliable diagnostics. And that still the definition of clinical variance is the basis for the treatment approach. So we need integrated prognostic models that, of course, improve our capability to separate patients, but the clinical assessment is still very important. So coming to treatment, well, we've already seen these, and I've told you about the fact that these two therapeutic approaches are quite different. But you know, in clinical practice, it can be sometimes it's not so easy, and also we are probably changing our approach in some specific subset that we will see. The first thing is the basis for treatment, as we've said. So what about the presence of B findings? We've said that they define the smoldering SM, but is the smoldering SM definition an indication to treatment? As we've said, it identifies a category of patients with a very high burden of disease, but it's not clear if that means that they will more probably progress within quite rapidly. It's not clear, and there's these interesting data coming from Mayo Clinic papers some years ago, showing that the fact is that smoldering SM, beyond being quite rare, so it's difficult to get robust diagnostic results in this setting, but they highlighted that patients with smoldering SM are actually older and have, of course, some mutations, but these mutations are generally those involved in clonal hematopoiesis rather than, for example, aggressive systemic mastocytosis. So adjusting the prognosis for age, the adverse effect coming from SM, smoldering SM was not evident. So it can be considered actually an indication to treatment. Rather, it's an indication to be careful about potential disease evolution. And the other thing is that, of course, C findings are due to organ damage, but not all C findings are the same. As an example, of course, we can have a patient showing a moderate cytopenia, like a moderate thrombocytopenia, but clinically, its clinical impairment is actually different from a patient with an acidic effusion, with portal hypertension, with hepatomegaly. It's a patient that is much more sick than the first one. And what is also different beyond the heterogeneity of clinical manifestation is the time with which these clinical manifestations progress. So we have cases that remain stable for a lot of time. And on the other side, we see patients deteriorating quite rapidly. Also, we need to assess on an individual patient cases. And the other thing is that the distinction between true organ damage or, in some cases, mediator-related symptoms, it's not easy. It can be easy. An example of this is the gastrointestinal symptoms. They can lead the patient to modify his diet, for example, to avoid some food, and can experience, of course, weight of loss. But you have to understand if it's actually a malabsorption with weight loss or just the modification of the diet that leads to that. And we do not have reliable tools for differentiating between these two situations. On one side, actual gastrointestinal impairment, and on the other side, the variability related to mediator-related symptoms. Well, another important finding that luckily it's quite rare is the presence of osteolytic lesions. But we have to state clearly that this is not osteoporosis. Osteoporosis is a very frequent occurrence in this patient, but has not to be considered a sign of an aggressive disease. Different is the case of a large lytic lesion that, it has to be considered on the other side as a finding, but it's important to perform a targeted biopsy because, a large lytic lesion in these patients could also be due to another disease. So it's important to define that is the systemic mastocytosis to cause it. Probably the most challenging and debated issue is the SM with AHN. Also because we have already said the majority of cases, it's an advanced myeloid disorder. It's advanced because we have multilineage involvement by KIT. We have so many mutations in what we call myeloid genes. Recurrent genes that are recurrently mutated in myeloid neoplasm, and the prognosis is bad. So actually, in many cases, it's like that. But in many other cases, we have to say that probably the capability to distinguish between the impairment by SM from the impairment by the other myeloid neoplasm is challenging. And probably in the literature, the actual presence of indolent systemic mastocytosis with AHN is underestimated because, the literature tends to publish and to report challenging cases and not indolent ones. So the recommendation here is once again, to specifically assess the individual patient and to understand if, in this case, we have an aggressive myeloid neoplasm, if we have an aggressive systemic mastocytosis or not. Also because there's this important report that has been published a few years ago from the UK, UK group, where they, gathered a group of cases that had concurrently JAK2 mutation and KIT mutation. And they demonstrated that in the majority of these cases, we had different clonally unrelated disorders that were separated, for example, an ET or polycythemia vera together with systemic mastocytosis. And the indolent cause was a feature for both the diseases. So these cases have not to be classified as advanced merely on the fact that you have another hematological neoplasm. You have to carefully evaluate single cases. So the first decision when we're talking about treatment is to adopt or not cytoreduction. And, the actual assessment of organ damage, the adoption of anti-mediator therapy, of a try of anti-mediator treatment to see the effect is acceptable, of course. And talking about indolent, smoldering, especially, but it could be the same also for advanced, what is avoiding trigger of mediator release? Well, dietary restriction, we do not use normally preemptive dietary restriction. Rather, we stimulate the patient to evaluate which kind of food induces mediator release and educate him to avoid these foods, like to have a diary and to record his symptoms. Well, as for drugs, there is a debate about the actual risk of reactions to drugs in patients with SM. In these cases, we state that skin involvement is quite useful because it's a sort of way to determining the age of onset. And all the drugs that the patient has taken in this phase from the onset on can be taken without any problem. There are no problems for vaccination. The COVID phase has learned us clearly this fact. The only recommendation is for a longer observation period after vaccination, but it's not considered a contraindication to vaccines. Well, pregnancy is a challenging situation. This disease can affect also young women, and they can ask for clarification about the opportunity of a pregnancy. We know that during the pregnancy, the mediator release symptoms tend to improve, even if it's not always the same, but generally it tends to improve. And a conservative management is feasible. The use of steroid is feasible as well as antihistamine treatment. In specific cases, you need to control some symptoms, even if I do not remember specific cases where it was required, but we know that the cytoreductive treatment that we can use safely is interferon, of course. Again, talking about the syndrome from mediator, and to control these symptoms, the use of antihistamines, of course, is the general rule. Now we use NTH1, of course, and for NTH2, there was a hold for ranitidine some years ago, but now we can use famotidine for especially gastric symptoms. We can use mast cell stabilizer. Actually, the one that we use the most is chromoglycate. This is the conventional dose that we use, even if there can be some modifications depending on patients. Some patients do not tolerate it so much. So, but in the majority of cases, there are no issues, and they can take that. Well, the Spanish group pushes a lot on chromoglycate to deliver it specifically, even in the absence of symptoms. We tend to use chromoglycate in patients experiencing gastrointestinal symptoms. The Spanish group pushes for the use of this drug, even if there are no symptoms. And of course, in each case, when we diagnose a systemic mastocytosis, the patient has to be provided and instructed, trained on the use of epinephrine, and provided with at least 2 auto-injectors of epinephrine. That is crucial, of course, to prevent anaphylactic reactions, or to prevent the consequences. So the wide heterogeneity of clinical manifestation actually calls for an accurate estimation of organ dysfunction, and sometimes this distinction between variants is not easy. So it's very important to assess and evaluate the individual cases. Coming to cytoreductive treatment, we normally say that we have some conventional drugs and some more modern drugs that actually are tyrosine kinase inhibitors. The indications for conventional drugs come from a very old study, but in some cases they can be used as well. The first one is interferon. Well, it's for sure quite rarely used now. We guess that with the pegylated formulation that is now again available, the tolerance to the drug is ameliorated. And the other thing is that in the presence of osteoporosis, it can have a specific action on bone that can improve the picture. But of course, it's an old drug, and in many patients, it's not well tolerated. Another still valid option is cladribine. That we know it's a conventional chemotherapeutic drug, and is useful, especially when a rapid debulking is needed, and can be an effective treatment as a salvage therapy in cases of loss of response to KIT inhibitors, for example. The concerns come from the known immunosuppressive effect, and so we have to monitor that. We have some published reports saying that it's safe to deliver up to 3 or 6 cycles of cladribine. But of course, the emerging approach is the inhibition of KIT. But there are some issues here to understand, which is the efficacy and safety. It can vary a lot depending on some, variables. So on one side, the potency of inhibition of the single drug, of course. On the other side, the selectivity and the fact that you can have some side effects coming from off-target inhibition. But another important issue is to which extent the disease is addicted to KIT, or in some other cases, especially if you have a concomitant hematological neoplasm, how can the disease escape the inhibition of KIT? Well, this figure represents the specificity of the kinome. The yellow dot is KIT, and all the others in the tree are some other TK that can be inhibited by specific agents. Well, among TK inhibitors, imatinib still has a very specific role, because in the literature, especially in the absence of KIT mutation, of the canonical KIT mutation, it can induce a response. We know that it doesn't work if you have the canonical D816V mutation, but if you do not have, you can try imatinib, because you have more or less 30% of probability of response. That is, that can be extrapolated from the literature. And especially in the well-differentiated SM that we saw before, that quite often is negative for canonical mutation, this drug can be effective. Well, we know midostaurin has been approved in 2017 by EMA for its use in advanced systemic mastocytosis. Well, the rate of response in this phase 2 study was 60% according to the Valent criteria that were used in that phase. And it's a quite tolerable agent that in some cases has some problems with GI symptoms, especially nausea and vomiting. These curves represent the long-term follow-up. An issue with this drug that now we know quite well is the fact that we have a low probability of response in the presence of high-risk molecular genetics, as those related to SAR, for example. Then we have the last one is avapritinib. You know that it has been approved on the basis of the results in this study, especially Pathfinder, that is the phase 2 study. And response criteria here were much more stringent than the Valent criteria used for the registration trial for midostaurin, and the overall response rate was very high, was 75%, with an objective reduction in the burden of the disease as assessed by bone marrow mast cells and serum tryptase that is quite fast, especially as compared to the observation that we see with midostaurin. These are the Kaplan-Meier showing that in pure aggressive SM, you can see the highest response, but also in the other cases, the survival curves are very good. Well, the fact is that we can be a little bit concerned about the impact of a TK inhibitor in general, and specifically of a potent inhibitor as avapritinib, on the non-systemic mastocytosis component of the disease, especially when you have an hematological neoplasms. We have some evidence from literature, the trend of monocytes and eosinophils, for example, during treatment with avapritinib, that has been collected and observed, and that shows the reduction in this non-SM population also with the treatment with a KIT inhibitor. But the fear, or the concern is the fact that we could see a clonal evolution of the disease. So a sort of escape of the disease on treatment with a KIT inhibitor. And there are some reports of an evolution, for example, into AML, acute myeloid leukemia, with the loss of KIT mutant and acquisition or emergence of clones featured by some other myeloid mutations. So probably for this patient, the fact and the actual improvement will be not only based on the development of more modern KIT inhibitors, but rather on the opportunity to combine KIT inhibitor to other treatment, more directed to the myeloid component, as for example, hypomethylating agents and other BCL2 inhibitors and so on, that could be sequentially used or combined with KIT inhibitors. And given the availability of such treatment that are specific, that can induce deep responses, also allogeneic transplant, of course, can become an opportunity. Historically, transplant in SM patient has been a very, very rare therapeutic option because it was actually very, very challenging to deliver the patient, to carry the patient up to the procedure. And the procedure itself was featured by very high non-relapse treatment-related mortality and by very unfavorable outcome. With the availability of this treatment, it could become also a very important option. What is also changing is the approach that we having in indolent form, because we are changing from a symptom burden control to the use of treatment that can induce disease remission, and with that, the improvement in symptoms. Well, we already know that KIT inhibition could lead to an improvement in clinical symptoms, also from the results in terms of patient-reported outcome and quality of life coming from the use of some KIT-directed treatment as midostaurin, for example, within the trial that led to the approval of midostaurin in advanced systemic mastocytosis. So the increasing impact of the drug on clinical symptom and on quality of life was evident. And so that led to the design of a trial that was dedicated to indolent systemic mastocytosis. That was as well an innovation. So a KIT inhibition for indolent systemic mastocytosis. That's the curve that depicts quite well that there's a reduction in symptoms also using lower doses of avapritinib with respect with the ones that are used in advanced variants. In this case, it's 25 milligram once daily, that led to an improvement in quality of life symptoms, also confirmed by the phase of the crossover, where you can see the curve that tends to superimpose themselves. So that led to the approval of the drug, even if, at least in Italy, it's not still available. We can't prescribe it within the healthcare system, even if the European agency has approved it for indolent systemic mastocytosis. And there are some reports on specific domains of the disease, from GI symptoms to skin lesions, that clearly demonstrate that an action that is no more on the symptoms, but rather at the beginning of the disease, so on the crucial mechanism of the disease, of course, tend to produce improvement also into mediator-related symptoms. So it's a change of the paradigm of treatment in this patient. Clearly, we have to state that vigilance of side effects, especially on long-term exposure, is mandatory, because we are talking about often young patients that has to take these drugs for many decades. So we have to be sure about the safety of their profile. And we know from the use of avapritinib in these trials that peripheral edema and hematological toxicity are quite manageable early to happen, and so we can face with that and manage that. What is more concerning and has to be evaluated in the next future is the cognitive effect, because we know that the drug can penetrate the the blood-brain barrier, and so we have to monitor on these effects, and also, for example, wait for some other drugs. These are molecule that is called elenestinib, have a lower penetrance, actually quite almost 0% of penetrance into the central nervous system. So for sure, it could be an alternative in terms of safety profile in the long term. And also this other drug that is currently on study, that is called bezuclastinib, is another option, another KIT inhibitor that can be available within some years, also for the use in indolent systemic mastocytosis. And actually, the use of KIT inhibitors is changing the way we are appraising, we are evaluating response. And what is, an evolution in the field is the fact that we have an approval of a drug in indolent systemic mastocytosis that was based not on a objective reduction of the disease burden, but just on just is a way of saying on patient-reported outcomes, so on the improvement of quality of life questionnaires. So the conclusion is that the fact that as per treatment, we now have a very important category of drugs that we use. We are already using in advanced variants that we will probably have it available also for indolent systemic mastocytosis within a few months, we hope. And these are very important options to control also mediator-related symptoms and not just for advanced variants. Well, some few words about eosinophilia. I would like to start from a clinical case that we observed in our institution. It was a male, 15 years old, that presented some years ago with leukocytosis and eosinophilia. You can see here the hemochrome. He underwent the conventional diagnostic procedure with these results that actually, due to the negativity for presence of T lymphocytes clone and molecular genetics that are normally associated with primary eosinophilia, PDGFR alpha, beta, and FGFR1, we concluded for hypereosinophilic syndrome. Well, there was a trial with imatinib that actually didn't work. There were skin manifestations, especially, and some other symptoms that were quite important, like bone and joint pain. And in 2013, we tried also with hydroxyurea together with steroids that were able to control the eosinophil count and partially the symptoms, but not so well. We performed another reevaluation to see what was going on, and actually the histopathologist observing a mast cell infiltration called for the search for the KIT D816V mutation that were positive. The tryptase was low, but the mutation was positive. And so we concluded for a form of systemic mastocytosis with eosinophilia. That it's not easy. I mean, to distinguish between these two different cases. We know that sometimes systemic mastocytosis can present with eosinophilia, and there are some overlap features between mastocytosis and other diseases involving eosinophilia. And what is important to say is that you need to exclude other neoplasms featured by specific gene rearrangement, because of course this can lead you to different type of treatment. And it's important to say that also patients with rearrangement in PDGFR alpha can harbor the aberrant expression of CD25 on mast cells. So that aids complication to the differential diagnosis. So it's important to search for both the diseases, but also to exclude myeloid lymphoid neoplasms associated with these fusion genes. what about the prognostic significance of eosinophils? We know from this study by the ECNM on a very large number of patients that there's a prognostic impact. So having eosinophilia in this patient can cause an adverse effect. We don't know why, of course, but we can hypothesize that eosinophilia in this case is a sort of surrogate for subtle hematological neoplasm that it's not sufficient to get a full diagnosis of another neoplasm, but is there, is underneath. And in the case you find eosinophilia in a patient diagnosed with SM, it's recommended to use NGS to highlight the presence of some mutations underneath. In this case, we tried a treatment with interferon twice a week, but it was interrupted after 6 months, either due to intolerance, but also due to a partial control in eosinophil count. And he had some flares that were, I mean, more typical of eosinophilia probably, or of an hypereosinophilic syndrome than systemic mastocytosis that were characterized by skin rash, pruritus, joint pain, and the patient actually needed to use steroids quite regularly within a month, with all the relative consequences in clinical terms. So in May 25, we tried also with midostaurin without any effect, and the patient was intolerant to midostaurin. So based on the presence of eosinophilia and the fact that probably some symptoms were related to that rather than SM, we also asked for an off-label use of mepolizumab. And the indication of the drug, we know, came from this trial that was in hypereosinophilic syndrome, where it demonstrated a fast effect on eosinophils and a reduction of flares in terms of percentage without specific adverse event limiting its application. And in August 2020, the patient started with the treatment with mepolizumab at the conventional dosage, and the eosinophil count quite rapidly became normal. It was possible to interrupt hydroxyurea and progressively, even if at the beginning it was not easy, but progressively to reduce the need of steroid courses in the long term. And now the patient from March 21 has not anymore the need to use steroids to control the flares. He has complete disappearance, that is continuing to treat with mepolizumab. You know, you have the systemic mastocytosis that is over there, quite stable, but the drug, it doesn't interfere with mastocytosis, but is able to control the symptoms. So it's a very interesting case from my point of view. And we could conclude, even if it's just the case, that in some specific cases, eosinophilia is probably part of the pathological clone, but sometimes can be also driver of the clinical symptoms. And I would like to finish here to thanking all the people at our center and in the Italian network that are involved in the management of patients with systemic mastocytosis, and of course you for your attention. Thank you.
Thank you, Dr. Francesco, for this great review. Now let's start a brief discussion and answer the questions posted in the chat. So the first question here is, do you test for alpha-tryptosemia in your clinical practice in all patients?
Well, not now, because we had an issue with the lab, so we used to test it until I would say 1 year ago, but then the lab had an issue and couldn't, continue. I specifically, on my opinion, is a useful test to use when you get a tryptase level that is moderately high.
That it's not normal, it's very high. Yeah. Okay. And you think that it's not only mastocytosis and maybe...
before undergoing, because making the patient undergoing a biopsy, it could be useful.
Okay. So the next question, in case In case of low suspicious of systemic mastocytosis with a low REMA score, for example, do you consider searching only for the mutation on peripheral blood sample, considering the high-end sensitive techniques? Do you have these sensitive techniques, or because only some laboratories do have these sensitive techniques?
Well, now we have digital PCR in peripheral blood, and it's a more sensitive technique. But as well, I think that in some cases of indolent diseases, you don't have disease in the peripheral blood. So for how much the technique can be, it can detect a disease that is not there. So the false negative rate remains. We use peripheral blood searching for KIT, but it's a way to, take time with the patient, to get the patient used to the idea that we need a biopsy. Of course, sometimes we can monitor the patient because it's not urgent to get a diagnosis, especially if the patient, for example, has epinephrine already prescribed and so on, has not abnormalities in the exams and so on. But we have to be aware that the fact that peripheral blood testing is not the same as the bone marrow biopsy.
Okay, but the next question, if you don't have access to avapritinib first line and you have rapidly progressive advanced mastocytosis, like a good acute mast cell leukemia, we know that midostaurin can take time to see results. Do you sequence or combine with chemotherapy, other cladribine or combination chemotherapy?
Well, if it's a mast cell leukemia, a pure mast cell leukemia, probably cladribine if a good try.
Okay, to reduce.
Yeah, to reduce, and also if the disease is related to mast cell disorder, cladribine can be quite effective. Otherwise, if you have mast cells and myeloid blasts, so an AML with mast cells, I would try a more comprehensive approach with chemotherapy together with a KIT inhibitor, for example, as midostaurin.
Okay, I think this is the next question here, and you have probably already answered that. Okay, another question. There is any relation between osteoarthritis and systemic mastocytosis?
So osteoarthritis, you mean?
Osteoarthritis, yes.
Well, as far as I know, no. You have to, bone disease in systemic mastocytosis can be quite variable. You can have osteoporosis, you can have osteosclerosis, you can have the combination of both. So in some cases, the patient can complain about joint symptoms, I would say, or bone pain, and you have to distinguish between these two situations. But there is, as far as I know, no demonstrated relationship between the two diseases.
Okay, thank you. Another question. Can you see the question? Oh.
Yes, but it's in Portuguese. And
this last is in Portuguese, yes. Do you know some relationship between mastocytosis and the genetic deficits of the
histamine.
enzyme histamine? Yes.
No, not as I know. As far as I know, there are. Well, I have no evidence on that, but because I see the colleague that describe a case.
Yes,
with
episode case, yes.
With recurrent episodes of angioedema. Well, angioedema, it's something that, but is also diagnosed with systemic mastocytosis, as far as I can see.
I can see. So the patient has systemic mastocytosis with angioedema since the 8 years until now. She has 45 years with a very low response to antihistaminics.
Okay.
Anti-leukotrienes, corticoids, and EpiPen. Sorry.
Well, it seems quite a a challenging case. In these cases, we interact, of course, with our allergologists, and what they are using as an off-label use that is quite useful, but especially with anaphylactic episodes. I don't know, with this kind of clinical manifestation, can be omalizumab.
Omalizumab, okay. Another question. Can you see it or no?
Yeah,
Do
you consider treating patients with midostaurin instead of avapritinib, considering KIT mutations? In 50% of MCL, we don't find the mutation. I mean, avapritinib is most selective. Is the best choice when you have other KIT mutation? Do you prefer that? Well, actually, the differences between these two drugs are that avapritinib is much more potent and selective. That is true. But if you have other mutations, unfortunately, in a mast cell disorder, midostaurin is not able to overcome the high-risk mutation. So I would probably prefer avapritinib, because if it's a matter of clones. If a KIT mutation is quite high and the other mutations are in the same clone, if you hit KIT, you can have some opportunity to kill all the mast cells, or all the clones. Of course, the risk, as I've said, is of a clonal evolution, of an escape from KIT, and the development of another clone that is KIT negative. But I do not consider midostaurin so sufficiently effective to be an alternative to avapritinib in these cases. Rather, I would consider a sequential treatment with the other treatment, like hypomethylating agent or chemotherapy, or also transplant. But I would prefer avapritinib in these cases.
Okay. So
well, I said osteoarthritis, but it's osteosclerosis. So okay.
Yes.
So the question before, yes, osteosclerosis is linked to is a different manifestation of bone diseases, systemic mastocytosis. So you can see, and it's also something that can turn on the clinical suspect of mastocytosis. The description of these salt and pepper aspect at imaging, at the radiography, is an important thing that you have to suspect the systemic mastocytosis. So osteosclerosis, yes, is linked to the disease.
Okay. So I have another question, because you said there is a subgroup in indolent systemic mastocytosis, bone marrow mastocytosis, and I see cases that are quite associated with anaphylaxis to immunotherapy allergy, and these patients need to do continue immunotherapy. Okay. This is your experience or not?
Yes. These patients are with very low disease burden, as we've said, and with very low tryptase and very severe anaphylactic reactions. But the issue is that the immunotherapy for Hymenoptera sting has to be continued for the whole life. Also because if you interrupt it, there's an additive risk of a very severe reaction. So there's clearly the indication to continue immunotherapy for the lifespan. And the thing is one of the things that, of course, the allergologists ask the hematologist to do, the biopsy, to conclude if it's a systemic mastocytosis or not.
Okay.
One reason is this.
Okay. The last question, do you always try to find mutations, additional mutations in smoldering mastocytosis like that too, or no?
Only in smoldering mastocytosis, we consider the opportunity to perform NGS, actually, not specifically.
You always do NGS?
Well, no, not always. In indolent systemic mastocytosis, we do not perform. But, if you have a smoldering, especially in a young patient, we prefer to do. We do it in advanced variants and in smoldering in selected cases. We normally do not do in indolent variants.
Okay.
Well, there's another one. How do you know if you have an Hymenoptera venom allergy if you've never been stung? Well, that's of course, that's
you never know. Until there.
No, what I've said is that it's the most frequent occurrence is that an allergologist refers the patient
So
to you due to
a bone
of
marrow
course,
exam.
to an
Okay,
anaphylactic shock. And in these cases, if you have a very severe anaphylactic due to Hymenoptera, the recommendation is to perform the biopsy, because you have to exclude the systemic mastocytosis. It's very important.
Okay, I think we have answered all the questions.
Well, perhaps to the last question, we can say also that the skin tests are not reliable from the allergologist point of view. So if the question was that, I mean, to perform skin test is not a substitute to the clinical. So if a patient has not been stung, you never know.
Okay, thank you very much. It was a great review, and we hope to see you soon. Thank you.
Thank you very much. It has been a pleasure for me.
Thank you so much, Dr. Francesco, for your great presentation. And thank you to Dr. Patricia Silva. Now I will talk in Portuguese. Queríamos agradecer sinceramente a presença de todos os participantes e esperamos que os conteúdos apresentados tenham contribuído para aprofundar o vosso conhecimento sobre estas patologias, que continuam a representar um verdadeiro desafio em termos de diagnóstico e terapêutica. A compreensão das mastocitoses está ainda em constante desenvolvimento, pelo que a formação contínua é essencial, e a APORMast pretende com estes webinar e outras iniciativas contribuir para esse maior conhecimento. Para a avaliação da sessão, iremos enviar-vos por e-mail um link para o respectivo formulário. Desde já agradecemos a vossa colaboração e preenchimento, pois a vossa opinião é fundamental para podermos melhorar continuamente. Caso ainda não o façam, convidamos a seguir a APORMast nas redes sociais e a visitar o nosso site www.apormast.org, onde poderão encontrar mais recursos, informações sobre as patologias mastocitárias, eventuais eventos e iniciativas. Muito obrigada a todos pela participação e até uma próxima oportunidade. Thank you so much. Bye.
Bye-bye.
Bye.